Perfect. So welcome everybody. So this is a special lecture in several ways, but partly because we have an esteemed international speaker all the way from the US, who is very early in the morning at the moment. It's my pleasure to welcome Dr. Z. Paige Larario, who is has got a very interesting and broad background of professional affiliations as a board certified neurologist, also a social worker and a psychotherapist. So if not completely unique in that combination, I think it must be pretty rare, and I certainly haven't met anybody with that combination of really important and interesting clinical and academic sort of backgrounds. Z is going to talk to us today about an overview of behavioural neurology care for transgender patients. And it's a particularly interesting and important topic that is very important for us all to be more aware of and be educated of. And Z has written some great publications in this area. So we're incredibly grateful for Z to come to talk to us today. But before we get started, just a few housekeeping points. Please put questions for the discussion at the end in the chat. We've put this Teams link, as we do for many others, in the public domain with Z's permission. And given the complex and sensitive nature of some of the things we're talking about, I'll just be fielding questions from the chat rather than people asking live questions, because we don't quite know who could be in the audience. So apologies for that slight change to the usual running of questions. And of course, this is an academic meeting, and this is a complex topic, so we'll be making sure everything is discussed in a respectful and appropriate manner. So as usual, click the button for transcription if you require translation, or for those who are hard of hearing. We'll get started. So thank you, Z, so much for coming to talk to us today. And over to you. I think your slides, if you could share them, should come up straight away. So we'll have about the usual 45-50-minute lecture and then time for questions at the end. And if people want to hang around for longer questions, that's great. But those who have to go at 1 o'clock, that's fine. So thank you so much, Z, for coming to talk to us today.
Thank you for having me, and thanks for the kind introduction. As mentioned before, I'll be discussing behavioral neurological care among transgender and gender diverse people, and you'll see the acronym TGD for transgender and gender diverse throughout the presentation. I'm Z. Paige Larario. I'm from New York City, and I'm a social worker, therapist, and neurologist. And yes, that is my legal name as of this summer, where I've had my court order to change my name to the letter Z. Here are my financial disclosures. I always include my positionality as a relevant disclosure, just because it shows what implicit biases I have in how I handle my research and clinical care. In terms of just some affirmation of gender and gender identity, you'll see that sprinkled throughout, and I'll be happy to field any questions just generally on the transgender community or on how to affirm somebody's gender or create affirming environments. These are my views. They don't represent the entire trans non-binary spectrum, and feel free to do education on your own time, talk about this with each other, expose yourself to discomfort, and be brave to ask the questions today that you might feel might not be something that you're sure of whether it will be sensitive or not. We're here to answer those questions. Here are some great in general resources. A lot of this is US-centric, but I just want to point out WPATH, which is a global organization which comes out with the standards of care for transgender healthcare. They just put out their most recent standard of care last year. It's a great document that goes through all the evidence and provides expert recommendations on how to manage the health issues of transgender and gender diverse people. Here's what we'll be covering today. In addition to what I've mentioned about affirming environments and overview of the TGD community, we'll also touch on the existing data on functional and somatoform disorders, pain syndromes, aging and cognitive decline, and medication interactions with certain hormone therapies that may be used with transgender and gender diverse patients. Just to go over some terminology that some people may find a little confusing or new, so we're all on the same page. Gender is not the same thing as sexual orientation. Somebody who is transgender or gender diverse may identify as gay or straight or bisexual. Sexual orientation is who somebody is attracted to. And that could also be nobody, and that is usually somebody who would identify as asexual. Gender is a cultural construct. It's not based on biology, but some people do change their biology to better match what their gender identity is, and that can be done through medications and certain surgeries. And when somebody expresses their gender in a way that matches what their gender identity is, how they express that gender to the world is known as gender expression. Here's showing the difference between sex and gender. Sex is not the same thing as gender. I do quite a bit of peer review, DEI peer review for manuscripts in peer-reviewed journals, and I often see this being used interchangeably. They are different things. Sex is male, female, and then some people identify as intersex, which means they have an intersex condition or a variation in sex characteristic. And sex is based on biology, chromosomes, reproductive anatomy, hormones, things of that sort. And gender is a social construct, and gender identity is a fixed, firmly held belief and concept of what a person's gender is. The way that I like to conceptualize gender is if you think about those water coolers with those cups to contain water that are shaped like a cone. Let's use that as a construct to describe gender. The walls of the cup are man and woman on the outer edge, and then agender, or somebody who identifies as no gender, is at the tip, at the bottom of the cup. And this cup is filled with water, so it's fluid. And in between man and woman, that water is the non-binary spectrum. And gender can be fluid. For some people, it shifts from time to time, and they may have a more masculine expression at one time and a more feminine expression at the other. And that does not make their gender identity any less valid. If some of that water spills out of the cup, I'd like to think of that as the genderqueer spectrum and genderqueer identity, because it's really breaking the boundaries of what we considered a gender binary, which no longer holds up in modern conceptualizations of gender identity. I know this is going to be a neuropsychiatric and behavioral neurology talk, but we also have mental health providers in this audience. And just in general, how we create affirming environments in our healthcare settings can be life-saving. So respectful treatment by healthcare providers reduces suicidal thoughts. Using chosen name in a clinical environment decreases suicidal behavior. So this could be a simple and life-saving intervention to use somebody's chosen name and their pronouns. And we're getting away from using the term preferred because everybody has pronouns. We just often assume what a cis person's pronouns are, but that doesn't mean they don't have pronouns. So we just call them pronouns, and the singular they, like they are going to the store. That phone is theirs. That could be referring to one person, and that is grammatically correct in the English language. And neopronouns, like myself, I use they, fair, fairs pronouns, but there are other common ones like sie, zir. And these are pronouns that often are used in younger generations of trans and non-binary people, and they're no less valid. All language is constructed, and language evolves over time. So to start accepting these new pronouns and respecting somebody, even if you don't understand their pronouns, is an important part of the gender affirmation process. I want to briefly touch on the intersex community, mostly because 40% or more of this community also identify as trans and non-binary, and they're often excluded from healthcare research on the LGBTQI community. Intersex is an identity that can be claimed by somebody with an intersex condition, or it may not be. Additionally, just to watch out for, there are a lot of non-disclosure of intersex conditions to families when young children are noticed to have a variation in sex characteristic. And often there are cosmetic surgeries that obviously a young child can't consent to. And they may not find out about their variation in sex characteristic until they're adult, and they had surgeries performed on them that may cause long-term sexual and reproductive dysfunction that lasts throughout adulthood. So there is a push in this community to delay just cosmetic surgeries that don't have a medical indication until adulthood, when the person's able to consent. I think a lot of the discussion we hear about trans identity is around gender dysphoria, which is a DSM diagnosis which originated within psychiatry. It's defined as the distress that comes from the incongruence of one's sex assigned at birth and one's gender identity. And so there it's really an ego dystonic condition that creates distress. And I think there are a lot of social and systemic factors that lead to that distress. And it's very pathologizing. It's defining the trans experience in terms of a pathological diagnosis. And so the ICD-11 most recent terminology is actually just gender incongruence, which is not a pathological diagnosis. Gender euphoria, on the flip side, is a community-based term that is just entering the peer-reviewed literature. I think I saw the first qualitative study discussing this in an LGBT healthcare journal last year. And it's defined as the positive emotions that comes from affirming and expressing one's own gender. And so that's thought to be a more strength-based term. Here's going to be a short overview of gender-affirming care. It allows somebody's sex characteristics to better align with their gender, and it often leads to a more consistent perception by others of what the desired gender is. Many who are transgender do not choose to go through a medical transition or a surgical transition, and that could be actually more than 50 or 60% of trans people, depending on the cohort. And there are very clear improved psychological outcomes for those with gender dysphoria who receive gender-affirming care. It improves psychological outcomes like suicidality, like depression, things of that sort. There are feminizing hormones that can be used and anti-androgens. And progesterone is something that may or may not be used in addition to estrogens to feminize in a trans feminine person. Masculine therapy is typically testosterone-based, and often there can be androgenic alopecia that occurs, and there are medications that are already in use for those, including those that are commonly used in the general population. GnRH agonists are something that's becoming debated, but are shown to be highly effective in reducing suicidality in young transgender people, including adolescents. And the purpose here is not to transition using GnRH agonists, it's to delay puberty, to allow a person to explore their gender and decide if they want to initiate a medical transition. Here's just an overview of some surgeries in trans feminine and trans masculine people. Top surgery is breast surgeries, bottom surgeries, either vaginoplasty or phalloplasty, or other types of surgeries like metoidioplasty, orchiectomy, things of that sort. And there are various other types of interventions like hair removal and removal of other reproductive anatomy structures that may be involved in hormone production. This is in the US, but I would imagine it translates elsewhere. depending on the local culture and how affirming or harmful the local rules and laws are. In some places around the world, it being transgender identity can be punishable by death. But in places where it's allowed to be more recognized and affirmed, rates of transgender identification can be as high as 1 in 200 in the general population. And then looking at younger generations like Gen Z, as high as 5% identify as transgender and gender diverse. And I know race is more of a construct that's prominent in the US, but we also see that a lot of people who are from Black or Indigenous or other communities of color tend to identify within the sexual or gender minority community at higher rates. This is from the American Academy of Neurology, which is mostly North American, but also has international representation as well. And it was a survey to see what neurologists' understanding of sexual and gender minority healthcare is. And sexual and gender minority, or SGM, just refers to the entire LGBTQI community, not just TGD people. And so there really wasn't good representation in the sample. There was a low response rate, but those who did respond to the survey said, we don't know how this would impact neurological illness or our care for neurological illness. So there is some knowledge gaps and training gaps that exist. We're seeing an increase over time of transgender identification. That's thought to be more so affirmation of gender, which allows more people to openly express their gender. But keep in mind, if our healthcare environments, if our research environments are not affirming, it may reduce our ability to recruit participants for research studies and get a better sample. Often the studies that are being done are qualitative or non-probability sampling. It's hard to get a population-based sample unless we recruit from community-based sources. So we do need to increase trust and representation if we want to do research on cohorts within our individual institutions. We also need to differentiate gender and sex, as I said before, and start including non-binary identities. Most of the research, until very recently, centers around man or woman, whether that's cisgender or transgender. Here is how gender and sexuality has been conceptualized from the last, we're looking at 70 plus years here. Just of note that homosexuality was removed as a pathological diagnosis in the 1970s, but transgender identity existed past that in various forms until 2013, when the DSM-5 replaced it with gender dysphoria, which is the distress created by the incongruence of gender and sex. And ICD-11, as I said before, in 2022, removed the pathologization of gender completely and just calls it gender incongruence. Right now in the US, there's a very harsh anti-LGBTQ climate that's sweeping across the country. Healthcare is being removed, and healthcare access is being removed for many transgender young adults and adolescents. And there are other, protections that are being rolled back. And while the UK does have protections, there are similar sentiments being expressed in media representation that is anti-transgender, whether that's regarding age of consent for transgender youth to receive gender-affirming care, or this concept of transgender exclusionary feminism, which basically does not recognize transgender women as women, which, based on the literature and our understanding of gender, is not correct. So this I wanted to show. We mentioned WPATH earlier. This is their provider directory. There is nothing on neurology right now at this point. So if somebody wants to find a neurologist who's gender affirming, there's no category for that. So we have a lot to do to catch up, and we'll see that there are neurological issues that we need to be aware of and that we do manage if we do have transgender clients or patients. This is an overview of the minority stress and resilience theory by Ilan Meyer, I believe first published in 2003. And this is read from left to right. And there are certain minority stressors and resilience factors that are within our control. Those are at the top, and those that are more systemic or interpersonal, and those are at the bottom. Stressors are things that increase biological stress, and resiliency factors are things that mitigate those stressors. And these drive our biological, psychological, and social outcomes that all influence biology and healthcare outcomes. Some ones that I just want to point out in minority stressors in the top left, being in the closet is a very stressful thing. And people who are in the closet who are transgender may identify as transgender internally for years before they tell another person that they're transgender, and that's due to fear of rejection. A lot of times negative coping mechanisms like substance addiction are used to cope with that stress. And these minority stressors. Then in terms of resiliency factors, expressions of pride, building community are very important in promoting a healthy lifestyle. And then at the bottom, we can see stressors and resiliency factors kind of go hand in hand. When there's non-affirming environments, that's stressful for a transgender person. Finding spaces that are affirming and moving to those spaces are ways to improve stress in transgender people. And we could do a lot as healthcare providers to advocate for those changes for our clients and patients. We mentioned that there are biological, social, and psychological outcomes that are the result of these stressors, and they're listed here. I wanted to also show a pictorial representation of what gender dysphoria may look like to a transgender person. And those are on the left. The top left is somebody who is expressing chest dysphoria. This looks like a transmasculine person. So their conceptualization of how their breasts may be affecting the distress they feel regarding their gender. Bottom left is a trans woman in the closet, feeling trapped like in prison. And then the bottom right is somebody who's being misgendered, which is like any microaggression consistent over time can really be building up the amount of pain and hurt a person feels when they're not being perceived to have the gender that they intend with their gender expression. Here's how we can create affirming environments. There's 5 categories that I've listed. One is using strength-based, affirming, respectful language. Having boundaries, like don't ask, about somebody's plans for bottom surgery or, like vaginoplasty without, a reason for a healthcare reason to do so. I notice a lot of times when we have healthcare trainees, we expect them to represent their community. We expect them to do work to create affirming environments, but that's a job we all have. We should have increased representation, but it should be community-based, and we should include TGD people in how we create our clinical and research spaces to be most affirming of trans identity. If we are allies, we should role model allyship. We should correct people if we notice they're misgendering somebody or not using their chosen name. That's really important and a very simple intervention that we all can do. And we should be increasing our knowledge on the SGM community and TGD community. And so this is a great first step to start this discussion, and I hope we can continue it after this one lecture. Here's a recent scoping review of the literature looking at neurological issues in the LGBTQI community. There was only one case report on intersex people, and there was very limited data on non-binary people. Most of the literature since the 1980s focuses on HIV care for gay or bisexual cisgender men, and 60% of the literature is just case reports or series. So very low methodological quality and doesn't include the whole spectrum of the LGBTQI community. Here's a sample patient case. This is a 19-year-old assigned female at birth college student named Maya, who started to develop hyperkinetic limb movements acutely 3 weeks ago. They're described as uncontrollable. Several of Maya's friends recently began using gender-neutral pronouns and changing their gender expression. The rest of Maya's neurological exam is normal, and there are signs of mood issues and class truancy that's occurring most likely as a result of these mood issues and her other symptoms. So what is the recommended treatment? CBT, physiotherapy, psychopharmacological referral for depression, affirming clinical environment, and reduced social media usage or some combination. And think about it. We'll go back to the answer in a little bit. And E, the social media usage, is something we're going to focus on. I imagine a lot of you are experts already in this area, but I don't know who signed in based on the Twitter post. So just to quickly go over the diagnosis change from DSM-4 conversion terminology to DSM-5 functional terminology, where the inclusion of inconsistent or incongruent exam features is an important part of the diagnostic process for functional neurological disorder. I think we're seeing, and we'll see this a little bit in the literature, that for FND and LGBTQI populations, there tends to be a skew towards younger age groups. And so this was a great, I think it was a review article discussing how to talk about FND to younger people, and obviously a very simplified way of describing it. But I thought this review in particular in Epilepsy and Behavior Reports was very good. I think this is a much more accurate representation. A lot of this is done using fMRI studies. I want to point out that it's a complex functional circuit, that it's dysfunctioning. Areas of the emotional and limbic networks, including the amygdala, may be hyperactive during people with symptoms of FND, as well, particularly when we talk about that patient case, Maya, how involuntary the symptoms felt to her. We look at the right temporoparietal junction and how self-agency is involved in these symptoms. There are also abnormalities in the attentional network, motor planning, and sensory motor networks as well. These are, to my knowledge, the only population studies that look at functional disorders in TGD populations. There really weren't many, or I can't remember any, that were on cisgender lesbian, gay, or bisexual people. So there seems to be some interest in the research so far looking specifically at transgender people in cohorts studies. And I don't believe there are any prospective studies looking at this, but basically they're finding a consistent finding that there's some higher proportion of people with either FND or other functional somatic syndrome who are transgender compared to the general population or a cisgender sample. And these are from several different areas around the world, including Australia, Europe, and US. And then there is one other study that looks at transgender people in Israel as well with fibromyalgia that has similar findings. There are several cases in the literature that were already in existence that shows some correlation between functional symptom and expression of functional symptoms and concealment of an LGBTQI identity. And in those cases, both reports and series, there was some resolution or resolvement of their symptoms after there was some affirming psychosocial support, or the person was allowed to come out of the closet and disclose their LGBTQI identity. I put one timeline here, and there is variations in how quickly this process occurs in the literature, but here was, I think it was just a 5-week period in a 14-year-old who developed functional symptoms, various somatic symptoms. There were some neurological issues like gait disturbances and fatigue and headache. And there was a workup, there was a neuropsychiatric consultation eventually, gender dysphoria diagnosis was made, and then shortly thereafter there was improvement of symptoms. So with this, literature in mind, we recently performed a scoping review of all functional disorders and functional somatoform syndromes in sexual and gender minority people. The inclusion-exclusion criteria is listed here, but it was basically inception to 2022, looking at peer-reviewed publications. And we excluded non-English language, but to be honest, there were very few that weren't in English. We initially had 2,940 records identified, and after exclusion of those that did not meet our IE criteria, there were 24 articles that were included in the scoping review. Here are the types of studies that were included. We could see that most of them were qualitative or case studies or case series, and there were no prospective studies. The most frequent diagnoses in the literature are fibromyalgia, FND, or somatic syndrome disorder. We, as the adjudicators of the literature, did apply current diagnostic terminology to those publications that were earlier in the literature that did not necessarily use these terms. So there was adjudication by 3 different neurologists or neuropsychiatrists who looked at this and applied modern diagnostic criteria to the literature that we searched. Most of the studies were North American. There were some Australian, European studies, as I mentioned before. There was some from South Asia and the Middle East. Most of the literature has been recent, particularly in the last decade or so. And we could see that as more modern diagnostic criteria is applied, we did find more literature in that area. So that was actually good for our literature review because it was using current conceptualization of what we believe FND to be. But there were quite a bit of research articles that did use conversion terminology and did not use a consistent neurological exam or medical testing to diagnose what these authors believe to be conversion disorder. We took out the case reports and series of FND just to get a better idea of what the clinical presentations were in these patients and what their clinical outcomes were. There were 6 case reports or series. The age was quite young, as I mentioned before, with a mean age of 16. There was only 1 transgender patient, so the majority were cisgender LGBTQ people. The clinical presentations were mixed. You can see the list here with functional seizures and speech and swallowing dysfunction as the most common. As I mentioned on the last slide, there wasn't really a lot of standardized diagnostic approaches used by the authors or reporting guidelines used for the creation of a case report or case series. Treatment modalities often included just a discussion and disclosure of an LGBTQI identity. Some used psychoanalytic therapy, but this was often because of the older additions to the literature, not necessarily the more current ones. And gender-affirming care was offered to 1 person, but as we said, there was only 1 case report of a transgender person in this literature review in terms of the case reports with FND patients. Here's a recent publication, actually, that was, I think, just came out a few weeks ago. It was in the UT Southwestern Pediatric Neurology Clinic. They looked at their first 4 patients who were adolescents with FND who happened to identify as transgender or non-binary. 3/4 of them were assigned female. Most of them were adolescents at the time they disclosed their identity and had onset of symptoms that were functional. Most of them had a gait disorder or at some point had issues with their gait in terms of their symptomatology. 3 of the 4 received gender-affirming medical care. In the one that did not, one of the parents was resistant to this identity and to medical care, and that patient ultimately was lost to follow-up. The 3 patients who we did have follow-up on did improve, and all of those people really had some sort of psychotherapy that was affirming, and at least one supportive parent. I mentioned before social media usage. And this study, which is controversial, by Lisa Littman, published several years now, came up with this hypothesis of rapid onset gender dysphoria. And this study was basically conceptualized because a lot of parents were concerned about the gender dysphoria of their children, and several other patterns that were noticed on how their children were using social media. Namely, that these people who were identifying as transgender were using social media to interact with and enter spaces for transgender and gender diverse people. And so the parents were concerned, thinking that maybe there was a connection between accessing these affirming spaces online and gender identification as transgender or gender diverse. Most of them were assigned female, and they only looked at the parents' perspective, not the children's perspective. And so that was a major limitation. They had to actually submit a correction of this publication in +1. Additionally, this publication has been used many times now to remove in legislation the healthcare rights of transgender and gender diverse youth. So it's a very important publication for that reason. And it does not fit with the transgender community experience or recent research that's been done to refute this theory, which has been used to remove healthcare rights of transgender youth. Here's 2 publications by Jack Turbin, who's at UCSF. The one was using the Youth Risk Behavior Surveillance System dataset. The other was using the US Trans Survey dataset. And it was looking at the 2 studies. One was looking at between 2017 and 2019, were more people identifying as transgender or gender diverse in this age set? And no, the answer was no. And then they also looked at what was the time between somebody realized they were transgender, gender diverse, and when they shared that information with another person. And that median time was 14 years, meaning that it takes a long time for a person to get the guts to start disclosing this to another person, if they do at all. And therefore, had Lisa Littman interviewed the children, there may have been a period of a very long time before they told their parents about their gender dysphoria, which means it wasn't rapid onset. And one of the reasons I want to talk about this is because we did notice this TikTok tics, or these functional tic-like behaviors that spread over the COVID-19 pandemic. And we do know that social media usage was involved, because those people who had functional tic-like behaviors were more commonly looking at social media content that had to do with Tourette's syndrome. And there were definite semiological differences between those who had functional tic-like behaviors and Tourette's syndrome. And so the concern is, could there be a social contagion here in how functional tic-like behaviors were spread, similar to other outbreaks of functional neurological disorder that we've seen in the past? And so this study by the Calgary group is important because they did look at social media usage during the pandemic. And I know anecdotally there were high rates of trans and gender diverse people who presented with functional tic-like behaviors during the pandemic around the world. And I believe from what I've heard, that ranged from about 8% of clinic samples to what we see here, which was about 40+% of the Calgary clinic sample were identifying as transgender or gender diverse. So definitely higher than we would expect from the general population. And although, as we said before, there may be higher social media usage around Tourette syndrome content in those who express functional tic-like behaviors, when we looked at gender minority people versus cisgender people, there was not differences in social media usage. So that was an important finding that would also refute Lisa Littman's rapid onset gender dysphoria hypothesis. The Calgary group also looked at disability and quality of life outcomes in those trans and gender diverse people who express functional tic-like behaviors, and they did not find a direct association between gender identity and either quality of life or disability, but found that both of those outcomes were mediated by depression and anxiety or increased rates of mood symptoms in transgender and gender diverse people, which led to worsened outcomes such as quality of life and disability. I wanted to touch on this because I thought it was a very interesting hypothesis that came out regarding shame in the onset and maintenance of PNES symptoms and functional seizure symptoms. This is from Lorna Meyer's group, and it's basically, just as I said, shame is a very powerful emotion, and I think why I like this hypothesis is that shame is a very prominent symptom that people with gender dysphoria or those in the closet concealing a identity may report or come to, say, a mental health provider to discuss their gender dysphoria. So if there is an overlap here between FND or functional seizures and shame, that could be a link between trans identity and FND rates that may be increased in this population. But that's all speculation, but it's something that should be considered for future research. Shame resilience is something that's becoming more and more prominent as a way to handle many psychological disorders. I want to say that it's a very hard thing for somebody to identify and name their shame, let alone to own it, empower themselves to talk about it and advocate for themselves. But if somebody's able to do that and advocate for themselves, express pride, these are resiliency factors that are noted in Ilan Meyer's minority stress and resilience theory. So shame resilience might be something to look into. And the other thought that comes up from Alex Karuglian's group from Fenway Health and Harvard is the idea that DBT, or dialectical behavioral therapy, may be a treatment for gender dysphoria. And we're seeing a lot of people with a borderline personality diagnosis that may actually be incorrect, and it's an inexperienced provider that's misdiagnosing gender dysphoria as BPD. So either way, DBT may be a good treatment option because DBT was initially developed by Marsha Linehan for borderline personality disorder. I wanted to bring up this because a high rate of transgender and gender diverse youth are identifying as neurodivergent and have a wide range of neurodivergent conditions. The one that I think makes the most is studied the most in the peer-reviewed literature is autism, but also ADHD, OCD, Tourette's. And so having a more neurodivergent friendly that accommodates people who are neurodivergent and how they're taught DBT skills that may not be as strictly manualized as Marsha Linehan's initial DBT workbooks could be useful here for this population. And for those who aren't aware, there are several domains of DBT: mindfulness, emotional regulation, distress tolerance, and then interpersonal effectiveness is the other one. And you could imagine that interpersonal relationships in a gender transition changes completely for somebody who's transitioning and everybody around them. And this is a great book series by D.M. Maynard. I highly suggest recommending it to your patients who are transgender and gender diverse. And one of the things that is noticed why these interpersonal relationships are strained during a gender transition is not just that any change is hard, but there's a sense of grief or loss. And whether that's physical or symbolic, it's there. And this could be loss of expectations or things of that sort. So being able to find empathy for both sides' perspectives, not just the patient, but also the fact that this is a grieving process for the family or for friends and things of that sort. But it's also something that we should coach parents and family through, because any amount of grief that's not expressed as acceptance is seen or perceived, or could be at least perceived as resistant from the patient. So I don't think social media usage is involved in functional neurological disorders in transgender and gender diverse people, but we need more study to figure that out. I do know that affirming clinical environments improves other neuropsychological outcomes. Depression should be treated if present. Physiotherapy is a good treatment for those with motor or movement disorders. And CBT is so far the only evidence-based psychotherapeutic practice for FND. And I mentioned some others that could be useful for future study. Let me just look at the time, and I kind of have some other things that I wanted to talk about, but particularly if we're treating pain syndromes that are coexistent with functional syndromes, please know that enzyme inducers like carbamazepine, oxcarbazepine can interact with feminizing or masculinizing hormones, and valproate may decrease testosterone levels. Additionally, antiretroviral therapies for HIV may interact with certain medications used to treat headaches. So particularly the older generation antiretrovirals like protease inhibitors. So keep those medication interactions in mind, and know that if you're stopping gender-affirming hormone therapy, that is a serious consideration and thing to do, because the effect it might have on psychological outcomes. So really working with a gender-affirming prescriber, if any changes in neurological medications are made, is important, because that could have serious impact on the psychological health of the transgender person if their medications like testosterone or estrogen are stopped suddenly or changed. I wanted to touch base on this briefly because it does come up. I know that these dopamine agonists are used a little bit less now for Parkinson's, but if we do see patients with Parkinson's and coexisting functional disorders, this should be something that we know about so that we can handle it sensitively and we're not surprised by it. So the cross-dressing community is kind of an entryway into transgender identification and exploration, similar to the drag community. And so there are many people who may identify as cross-dressers and express gender nonconformity, who may or may not identify as trans, and either way is valid. But as we can see, there are certain paraphilias that are associated with dopamine agonists, particularly those that may be used for Parkinson's. So we have to be aware of that in case somebody comes to our clinic who expresses these gender nonconforming behaviors. And I put this up. This is Rudy Giuliani, and I believe on media was shown cross-dressing on several occasions back in the 90s. And I put this up because it often causes the audience to laugh. And I just want to point that out, that if this was our patient and we were in an examining room with them and their family and we laughed, that could be very harmful to our therapeutic rapport with the patient, with their family. And we need to be aware of that and how to address it sensitively, and how to refer this person to the appropriate providers that can provide affirming healthcare just to help with the distress this may be causing the family. And again, this is not saying these people are transgender. It's not saying that ropinirole causes transgender identity, but it may unmask some gender nonconforming behaviors in those who have expressed it previously. There are in the WPATH provider directory behavioral health services, and so that's how you can find somebody in your area who could address this with your patient. So for this case that I had up earlier, we would provide them empathy, affirmation, and we could discontinue the dopamine agonist because there are other options for people with Parkinson's. We need to create affirming environments. It's all of our jobs. And if we want to provide maximal neurological care and neuropsychiatric care, we need to do that. We should be good role models and be there and correct people if they make mistakes. We need to create new course content and more literature on this area so that we can teach and increase our knowledge. We need to create multidisciplinary collaborations, including those with external stakeholders like the World Professional Association of Transgender Health, who make the guidelines for our neurological care. We need community members to be involved in participation with all stages of research so that the research is less biased and also is more representative of the community we are studying. We need to recruit transgender trainees into our professions, and we need more prospective studies, both of treatment and natural histories of this vulnerable population. So please follow me on Twitter. We also have a gender equity working group within the LGBTQI section of the American Academy of Neurology. So if you know a transgender trainee who needs support or mentorship, please refer them to myself or Dr. Ziegler, who's a out trans neurologist at Albany Medical Center who currently chairs that group. Thank you very much for your time, and I'm here to answer any questions and happy to stay a little late to answer questions as well.
There's a bit of a microphone thing there. Sorry about that. So we had a round of applause. Maybe do it again whilst we're doing that. Brilliant. Thank you. Fantastic talk, Z. Great to have such a clear walk through such a complex area that many people will be partly familiar with. So thank you. So do put your questions in the chat. But in the meantime, one question I have is, you obviously the link between FND and gender diversity you highlighted, and then you mentioned neurodiversity later on. And within FND, as you know, there's a lot of interest in the overlap of previously unrecognised high rates of autistic spectrum disorder, particularly in FND patients. And as I understand it, there's a fairly established link with autism that you alluded to. And could that be the crossroads of those of FND, predisposition, ASD, and gender diversity? Perhaps there's something interacting in all those three things. And I know just because of, you said, I think within the TIC patient cohorts, certainly the ones also in South London that you're aware of as well, there was high rates of gender diversity and other issues. So we also have Francesca Happe, one of the sort of, I just noticed her, she's on the call as well as a sort of one expert on autism. So it was really just thinking about that area and perhaps there's something, we're starting to think about the sensory motor interactions and processing within autistic spectrum populations and whether that might be something around that could be predisposing to FND, but it's just that mix.
Yeah, I think that link is, and I'm in New York City, so there's a lot of construction right outside my window if you hear drilling. But
we've got some here as well, actually, so we're in sync, but we don't know where it's coming from, but it's fine. Thank you.
Yeah, so that link has been established looking at, cohorts of people with autism who identify as trans, and then looking at trans samples who, what proportion of transgender people have autism. And so there seems to be higher rates of autism diagnosis in transgender people. The exact cause of that is not really known. I think some ideas in my discussion with trans people who identify as or identify as having autism or diagnosed with autism is that there may be a social component like social dysphoria may be experienced differently by the two populations. And then another one that came up that I thought was interesting is sensory issues, that certain types of clothing in AFAB people may be discomfortable in terms of sensory stimulus that may prompt certain types of other clothing to match gender expression, like masculine clothing is more comfortable. But I do wonder if social dysphoria is something that's a real part of gender dysphoria, and how things are perceived socially with her gender expression is important. So I wonder what the link is there, and it's something that I think needs to be addressed sensitively.
Great. Thank you. So Tom Pollack has a question. I'll just read out. Thanks for a fantastic talk. I have a sense, perhaps that I've encountered TGD people more commonly than one might expect in a group of patients with joint hypermobility, Ehlers-Danlos syndromes, who present with neuropsychiatric problems, sometimes FND. Just wondering if you know of any data around hypermobility, Ehlers-Danlos as well, and TGD.
Yes, I know that there's increased diagnosis of Ehlers-Danlos in transgender people. It's association that's becoming more apparent. I think what's interesting too is that diagnoses are overlapping too, that we're seeing in people who are trans that have Ehlers-Danlos and other neurodivergent conditions. So there may be a pattern that there might be multiple diagnoses here in the transgender community. But there is a lot of hesitancy, and rightfully so, of transgender people to be studied by us in this type of research, because we're just going to pathologize maybe trans identity is pathological or involved with other medical disorders, when it's really part of a core identity that is not caused by other medical disorders. So how that's assessed needs to be done with input from the communities involved, so that we're not studying things that they don't want to be studied. And if we do study it, it's in a way that will not create more medical information, more medical misinformation, particularly that may be used later to remove the healthcare rights of transgender people.
Tim, you're on mute.
Thank you. I'm not sure how I managed to mute myself, but somehow I did, or someone else did. Yeah, I don't think we got the me talking about Maria's comment, which was really that in the chat here, that reflecting that gender is a social construct. So for people with autism, perhaps their gender is a more challenging, longer journey. So I don't know if that's something there's evidence for, or people with or clinicians would agree with that. Francesca Happe, one of the autism researchers here, who I mentioned, said, wonderful talk, thank you. Camouflaging of autism may be important in relation to Z's excellent point about shame versus acceptance. So I don't know if you've got any reflections on those 2 points around ASD as well, Z.
I'm not sure whether people with autism have longer periods between identification or first realizing transgender identity and disclosing that identity. So I just don't think the literature's out there on that. And I'm not sure how autism might affect that. It's an interesting question, but gender identity is formulated around age 3 or so, and we're liking to say that this is a core part of an identity, and often once gender dysphoria is explored in therapy and the trauma around living in a society that rejects trans identity, people may also unlock memories of earlier identification as transgender, from early childhood. So that's something to think about too. I don't know how camouflaging of autism or masking could affect gender. I'm not sure if there's a link in the literature. I haven't seen anything like that.
Yeah. So I think just before we close, I think, unless there's any other questions in the chat or in the room, I think very instructive to me that you're the case, or at least thinking about the potential within FND and maybe other conditions of somebody, with shame or stress from not revealing or expressing, or still being in the closet about their gender or sexuality, and how that might be something in the mix for the evolution, the point at which FND symptoms or any other condition that might be influenced by the mix of stress and their predisposition. So I think for me that's a really interesting point, and I guess to sort of see how we suspect that having that in our minds as something relevant, and whether we as clinicians can help in that. And I think, as Z points out, we can all do what we can to educate our colleagues and to be more aware of how to affirm gender and other issues in our patients. So I think it's brilliant to hear all about this in detail and so clearly and concisely put. So thank you, Z. One more time, we're coming up to the hour, so a round of applause again for Z. Thank you. So thank you so much, Z, and we'll have another meeting in 2 weeks, so hopefully see you all there. Thanks.